Good evening, everyone. Welcome to Uno Physio's second webinar on ulnar-sided wrist pain. Is all ulnar-sided wrist pain a TFCC tier? So welcome to all again. So we are starting the topic. So I just wanted to introduce myself. Myself, Anusha. I'm a senior sports physiotherapist working with Kelo India State Center of Excellence. I have an experience of 8 years in the sports field. I work with several prestigious sports institutions like Sports Authority of India, Naval Tata Hockey High Performance Centers, Indian hockey team, Indian football team, Indian basketball team. And based on my experiences, I always consider ulnar sign wrist pain is one of the challenging complaints we used to encounter in clinical practice. Even we see a lot of TFCC cases also. Is it really responsible for every case of pain on ulnar side of wrist? I think it is not. So because there's a wide range of conditions such as tendon disorders, ligament injuries, DRUJ pathology, ulnar impaction syndrome, fractures, and nerve conditions that shows pain over the ulnar side. But we always look into TFCC. So this can lead to misdiagnosis, and that may be leading to an ineffective treatment for the patient, and there can be a prolonged disability also. So in this webinar, I want you to have a different mindset, and I want to change the way you evaluate and treat the ulnar-sided wrist pain. So here we're going to start the webinar on ulnar-sided wrist pain. So why ulnar-sided wrist pain is complex? According to surgeons, ulnar-sided wrist pain is considered as the black box of the wrist actually. So black box means, it is the area which is a very complex area in everything. So in the case of wrist, it is the most difficult area of the wrist to diagnose, even for the surgeons. So you can identify how it is difficult because there is lot of structures. Actually, there is more than 20 different structures over the ulnar wrist area. And any pain or any instability or any injury to any of the structure will join or it will show the pain over the other side also. So the symptoms will. So that is the reason identifying the exact cause of ulnar wrist pain is difficult. And here we are focusing on how we can practically develop a diagnostic framework which you can apply in your daily clinical practice in cases of ulnar wrist pain. So that is our target today. So if you get a patient with a ulnar sided wrist pain, may it be a housewife, may it be a sports person, or any normal worker, and you got the patient, you are clinically assessing the patient, and once you assessed, then you are sending for an X-ray. If the X-ray is coming normal, then you suspect a TFCC injury in that case. Then you send that patient for an MRI. In most of the cases, there can be TFCC degeneration in the patients at the age above 40 years. But that doesn't mean that TFCC degeneration is the cause of wrist pain. So we will dive into the topic deep. You can see what are the structures. First, we will discuss what are the structures we can see on the ulnar side of the wrist. So you can see a TFCC, that is a triangular fibrocartilage complex, and extensor carpi ulnaris tendon, lunotriquetral ligaments, distal radio-ulnar joint, pisotriquetral joint, ulnocarpal ligaments, ulnar artery, and nerve. And especially the major carpal bones, the hamate and the triqueter. So these many structures are there in the ulnar side, and injury to any of these structure can produce pain. So in my OPD, when I encounter with wrist patients, for me, the first assessment will be based on their strength, their grip strength. Because if we palpate the patient in the first position, then what happens? That can elicit a pain response, and that will hinder our assessment process. So first we can go and check the strength by using a hand dynamometer or any equipment, like different hand dynamometers are available. So you can check the grip strength of the person firstly, then we can go move into the palpation. That is a better way to assess the risk cases. Because if we start palpating it, then that can elicit the pain, and the patient may not be much cooperating, and they will complain of pain with every movement. So that can hinder our proper diagnosis. So the structures we saw, and next we are moving to the TFCC. You can see in the image the structures on the ulnar side, TFCC, ulnar collateral ligaments, ulnar lunate ligaments, unotriquetral ligaments, physiotriquetral ligaments, all the ligaments, bones, everything you can see. So the basic requirement of the wrist is to transfer the weight of the upper limb, or utilizing the force of upper limb to execute a function, right? So if that's the case, whatever the force comes to the wrist, the stabilizing role goes to the TFCC. TFCC is a triangular fibrocartilage complex which have ligaments, cartilage, as well as some connective tissues. So major role of this TFCC is the stabilizing role of the distal radio-ulnar joint. And the TFCC also cushion the forces that comes to the wrist. If you go to the research studies, there is only 20% of the force that goes through the TFCC. Remaining 80% goes to the radial side. So TFCC have to handle only this 20%. And this is a structure which have articular disc, meniscus homologue, ECU subsheet, ulnar-lunate ligament, and ulnar-triquetral ligaments, along with radio-ulnar ligaments. So these many ligaments are there. And the major function is rotatory stability. Whatever rotation movements, rotation, supination, whatever you do, the stability should happen at the level of TFCC. And an injury that happens to TFCC, the most commonest mechanism of injury to CFCC is a fall on outstretched hand, or a sudden twisting movement, or any repetitive loading movement. These are the major causes of injury to the TFCC. But the major requirement is we should identify whether the TFCC is affected or not clinically. That is a major aspect in the assessment. So when we goes to the patient cases, nowadays we can see MRI, everyone go and take MRI. As per research, even MRI findings show TFCC that may not represent the pain is coming from TFCC. So as clinicians, we should perform the clinical test to identify the structure involved. Because in many asymptomatic athletes or any patients, the MRI abnormality will be there, but that is not the indication of the pain, because the TFCC can degenerate with the age. So that is a very common thing. So we cannot say ever TFCC is causing ulnar wrist pain. So let's start the discussion or the assessment. First, we know how to palpate the carpal bones. As we know, there's 8 carpal bones are there from the lateral side: scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. But palpation of these carpal bones is very important in case of wrist rehabilitation. So I will show you the video how I used to palpate the wrist carpal bones. So let's see. Hi all, today we will learn how to palpate the carpal bones in the wrist. So we will discuss about the bony landmarks of the wrist. Here we are going to palpate the carpal bones of this patient. So the patient's forearm is rested and relaxed over a table. Now first of all, we are going to assess the scaphoid bone. To check the scaphoid bone, we will tell the patient to extend his thumb. So once he extends his thumb, we will go and palpate the anatomical snuff box. So this area, anatomical snuff box, the floor of this snuff box is the scaphoid bone. This is a scaphoid bone. If any tenderness occurs in this area, that shows they have scaphoid fracture. Here we are going to palpate another carpal bone, which is lunate bone. Lunate bone is distal to the Lisserine tubercle. This is the Lisserine tubercle, which is on the radial bone, radius bone, dorsal aspect, and distal to that, if you draw a line through the third metacarpal, this line contains two carpal bones. The one near to the Lisserine tubercle is the lunate bone, and the one just above the lunate bone is the capitate bone. If you want to palpate it more prominently, it's better if you flex the wrist. You can see the prominence of the lunate bone. This is a lunate bone, and if there is any vascular necrosis of this bone happen, that is the Kienbock's disease. Now we are going to palpate the triquetral bone, which is in the dorso-ulnar aspect of the wrist. And if you want to see it very prominently, it's better to make the radial deviation, and you can palpate the triquetral bone. And any injury, any fracture happens to this bone, then you can feel the tenderness over this bone. Here we are going to check the another carpal bone, which is the easiest palpable bone, which is a pisiform bone. It's a very round, small bone over the ulnar and the palmar aspect of the wrist. And this bone actually lies within the flexor carpi ulnaris tendon. And this is an important landmark for the Guyon's canal. Next bone we are going to assess is the trapezium. This bone is at the base of the first CMC. So it happens to be in this area. So you can see the significance of this bone is that most frequently the osteoarthritis happens at this joint. Now we are going to palpate the capitate bone, which is the largest carpal bone, which can easily be palpated with slight wrist flexion and extension. And this carpal bone is in line with the third metacarpal. So if you draw a line through third metacarpal, this bone comes this area. Now we are going to palpate the hamate. Hamate bone is actually a very difficult bone to palpate, but it have a hook which is easily palpable just near to the pisiform bone. If you go little medially 2 to 3 centimeters, you can find a bony prominence. This is the hook of the hamate. And hamate is a very important structure because it forms the boundaries of Guyon's canal, where the ulnar nerve travels. And the fracture of the hook of the hamate is very common in baseball players. The last carpal bone which we are going to discuss is a trapezoid, which is difficult to palpate because it is lie deep between the trapezium and the capitate, and it is beneath the second metacarpal. So because of its position, it is not able to palpate in the routine examination. Hope you are clear about the palpation. So just now we discussed how we palpate the carpal bones. See, the carpal bone palpation is very, very important because if you don't know how to palpate the bone, we cannot go for the examination of the bone and do the special test. So it is very important to go through the video when you get time so that you will be thorough with the palpation. So once we palpate the bones and we know how to check the bone position, we are going to go through a diagnosis procedure. So we are going to start with the 3-story model for ulnar-sided wrist pain. That means you can see in the image, there's a 3 color markings, red, yellow, and violet. So the structures of the wrist just above the ulnar styloid. Ulnar styloid is considered as a central landmark. So the just above the ulnar styloid is called upper story, and the structures at the level of the ulnar styloid is called middle story, and the ones below the ulnar styloid is called lower story. So if they get a patient with a wrist pain, ulnar-sided wrist pain, you have to go and palpate the ulnar styloid process, and any injuries of the patient just above this area, that is above this there is a area of the radiocarpal areas, distal radioulnar joint is there, CMC is there. So this area will goes to the upper story, and the structures at the level of the styloid, that is the TFCC, these structures will go under the middle story, and the structures below in the sense the joint is the lower story. If you identify the condition of the patient based on this level, upper story, middle story, and lower story, then it is easy for you to reach the diagnosis. So I will explain it more. So we will first go with the upper story, that is the distal radio-ulnar joint. So distal radio-ulnar joint is the upper story one. So it is a joint between the radius and ulna. There's a proximal radio-ulnar joint as well as the distal radio-ulnar joint. And that is a very commonest place of injury as well as the production of pain. So how we will identify the patient's DRUJ is affected or not? So we have to go through a test called DRUJ instability test. That is the Ballotman test. So if you get a patient, first you have to find out in the palpation which area the patient have the point of maximum tenderness. If the patient complains of maximum tenderness over the upper story area, then we can differentially diagnose two conditions over there. One is the distal radio-ulnar joint DRUJ instability, and second is the foveal attachment of TFCC injury. That is, TFCC have a fovea. So if the fovea is affected, then that can produce pain over the upper story area. So there's two differential diagnoses in the upper area, the area just above the ulnar styloid. Very important. Ulnar styloid is considered as the major landmark for dividing this wrist into the three stories. So just the structures just above the ulnar styloid is considered as the upper story structures. The major structures of this area that got injured in the wrist are distal radio-ulnar joint, DRUJ, and the foveal attachment of TFCC. So again, DRUJ, most commonly distal radio-ulnar joint get into the instability. So if the DRUJ instability is there, we have to check the DRUJ Ballotman test. If the test is positive, then we can conclude it can be a DRUJ problem. And if we are doing the TFCC fovea test or fovea sign and the patient shows positive, then we can identify the case as a foveal attachment of TFCC tear. Hope this is clear. So how we are going to do the test? So DRUJ, very importantly, distal radio-ulnar joint. The joint have its own stability with the ligament structures. And if any ligament injury happens or the DRUJ got unstable, then the movement of the ulna and radius will be more. So we will check the movement of the DRUJ by this test, and we will identify this is a Ballotman test for DRUJ instability. Very importantly, just see the video. Now we are going to perform a distal radio-ulnar joint instability test. The test name is Ballotman test, DRUJ Ballotman test. And for performing this test, we will keep the hand facing upward, and we will hold the patient's radius with the one hand. We will stabilize the radius, and we will move the ulna. We will hold the ulna and move the ulna dorsally and palmarly. If there is a increased movement or the patient complains of more pain or symptoms during this test, then the test is positive. So hope you are very clear about this test. It's very easy test. You have to hold the radius and move the ulna dorsally and palmarly. And this test can be done in various positions. First, you can try in this mid position, then you can try in the ulnar deviated position to make it more difficult for the patient so that we can identify the DRUJ instability. Suppose our patient shows negative result in this test and there is no pain when we do the ulnar movement and there is no increased movement in this area, then we can suspect it can be a TFCC fovea injury. So to confirm the TFCC fovea injury, we will do the fovea sign test. So how to do the fovea sign test? We are going to assess the TFCC of this patient. If there's any TFCC injuries there, we will check the patient by using the test TFCC ulnar fovea sign. So to perform this test, we will keep the patient in the arm relaxed keeping over the table. The soft spot between the pisiform bone, flexor carpi ulnaris and the styloid. This is a soft spot, and pressing over this spot, if it elicits pain or tenderness in the patient or any reproduction of symptoms, that means the patient's TFCC got injured. So TFCC fovea sign, very important. So where you have to palpate between the styloid, flexor carpi ulnaris, and below the pisiform. You have to go to the soft spot and press. If there's a tenderness over that area or reproduction of pain, that means TFCC fovea sign is positive. That shows there's an injury to the TFCC. So these are the two injuries we see in the upper story. So what about middle story? Let's see. So the middle story, the structures again, TFCC articular disc. Again, we already say TFCC have different structures. There's an articular disc is there, ligaments are there, fovea is there. So in the middle story, we can see TFCC articular disc. And if that got injured, then we have to find it out by performing TFCC load test. The second structure in the mid-carpal, the middle story, is the ulnocarpal joint. And the third structure is the lunotriquetral ligament. So the three major structures, again, TFCC articular disc. How we will check the articular disc? Again, there's another special test, TFCC load test we can do. If that test comes positive, then the patient have injury to the TFCC articular disc. How to do it? Very easy, TFCC load test. You have to do the ulnar deviation and provide the axial compression to the patient. Ulnar deviation along with axial compression that causes articular disc compression, and then patient reproduces pain, then the TFCC load test is positive. Then what is ulnocarpal impaction syndrome? Ulnocarpal impaction syndrome is if the ulna is elongated, there's a positive ulnar variance. If the ulna is low, in some people it is low. So if that is the case, then it can cause impaction or pressure over the carpal bones. And that can result in the ulnocarpal impaction syndrome, which can only be found out with an X-ray. So X-ray is important if you suspect ulnocarpal impaction syndrome. There's no special test specifically for that, which is of not much of reliability. Then the third structure is the lunotriquetral ligament. Lunate, we already discussed. Lunate is the bone which is at the level of mid-carpal, so, third metacarpal. So lunate and the triquetrum, these two structures have a ligament in between that, and any injury to the lunotriquetral ligament happens, then we have to find out through the lunotriquetral shear test, which is a very important test to check the issues in the middle story. So again, middle story, three structures are there, TFCC, ulnocarpal impaction, and the lunotriquetral ligament injury. These things we have to look for. So TFCC load test I showed you now. Then lunotriquetral, we are going to see how to do the lunotriquetral shear test. It's called shuck test to identify lunotriquetral ligament injury. here we are going to assess the lunotriquetral ligament stability. So if the patient is got an injury in the lunotriquetral ligament, then there we can find the instability, and this test is called lunotriquetral ballotment test. To perform that test, we should keep the patient's arm in a relaxed pronated position. With one thumb, we will hold the lunate, which is in the line of third metacarpal, and we will hold the triquetrum with the other hand, and we will move the triquetrum dorsally and palmarly. If there is a increased movement or any pain reproduction happens, that shows there is a lunotriquetral ligament injury. So that's about shuck test. We are checking the triquetrum by immobilizing the lunate. Now we are going to the lower story, that is a structure just below the ulnar styloid. Major structures are the pisotriquetral joint, so the then pisiform bone, hook of Hammett, ECU, and the FCU tendon. So these are the major 5 structures at the lower story. Again, so the pisiform bone is a bone which is very easily palpable, and any injury happens to this bone, like any, we have to perform the physiotriquetral grind test. That is a moving the pisiform by stabilizing the triquetrum. That is a grind test. Then the hook of Hammett, very importantly, you can palpate the hook of Hammett. So any tenderness of the hook of Hammett shows there can be a fracture. And the most important test in this lower story is the ECU test, that is the ECU synergy test. This test is to be performed in order to find out the ECU instability, extensor carpi ulnaris instability. You can see by performing this test. So you can see here we are going to discuss the ECU synergy test. It is a test to identify the ECU injury. This extensor carpi ulnaris tendon. The function of this ECU is to do the ulnar deviation of the wrist. So to perform the test, we will palpate the ECU with one thumb, and we will hold the thumb and the 2 fingers, and we will tell the patient to do the ulnar deviation, and we will resist the abduction movement of the thumb and the index finger. While performing this, if the patient complains of pain, then the test is positive. So the ECU synergy test, again very important, extensor carpi ulnaris, we will check by ulnar deviation and the resisted abduction. So this is the major structure in the lower story. So this is the way we can diagnostically assess the wrist injury, mainly the ulnar-sided wrist pain. This is different for the radial side. So the key for examination is whatever test you perform, identify the level of maximum tenderness and identify the structures which through the propagated test. So here's a case we can discuss today. It's a patient who got in the OPD with a 46-year-old housewife. Her major complaint was the pain over the ulnar side of the wrist for last 4 months. And her history is there is no history of fall or injury, no traumatic events. Her injury cause is by lifting a bucket of water. That is also 5 months ago. So she has not taken in treatment that time. And her present complaint is she have increasing pain on the little finger side, and that increases with the winging of it, close, opening tight jars, lifting heavy vessels, all those things. And even now, presently, she have pain with the chopping activities also. So her pain is a dull leg pain at rest and sharp pain during twisting activities. And there is no numbness, no tingling. That means the neurological signs are excluded. That is, neurology means ulnar nerve is passing through the ulnar side through the Guyon's canal. So if any issues happens over the ulnar nerve, then there can be tingling and numbness. So these structures are not affected. When we examine the patient, there's a swelling over the ulnar side and tenderness over the distal to the ulnar styloid. Distal to the ulnar styloid. So when we check the range of motion, flexion is full, extension is painful, and supination is also painful. And when she do the ulnar deviation, that can produce the symptoms, and the grip strength is reduced compared to the opposite side. So can anyone tell me what can be the test we can perform in this case? We can perform all tests, but see, doing special test for all the structures is not a good idea because special test reproduces pain. So patient may not be tolerating that much pain. So we have to narrow down our diagnosis to specific test. So in this case, she have pain with the activities that cause rotation of the forearm, right? Bringing weight close, all this have a rotation component. So if a patient complain of pain with the rotational movement, we can suspect a TFCC there. So we can do a foveal test, foveal sign we can check. And if it is positive, we can again test it by TFCC load test. So we should at least perform 2 or 3 tests to confirm TFCC itself. So that is something we can do in this case. And why I'm not doing other tests in this case is because the symptoms is not showing problem of the other structures. So again, another case we are going to discuss, a middle-aged office worker with a persistent ulnar side wrist pain. So here a patient, again, history of a wrist pain for last 8 years, and he have a traumatic history, slipping on the wet floor and landing on the outstretched hand. And pain, there's a pain, mild pain and swelling. Again, lifting, gripping activities are more affected. Especially the problem is with heavy lifting dorsal brachts. And the nature of the pain is a dull ache at rest, sharp pain, twisting movements. Aggravating factors, ulnar deviation, gripping, lifting, forearm rotation. You can see all the symptoms, palpation. When we palpate it, the patient show tenderness over lunotriquetral interval. That means between the lunate bone and the triquetral bone, the patient felt tenderness. So if there's a tenderness over that area, we should check which test. You can respond in the chat which test we should perform if the patient complains of lunotriquetral interval tenderness. Please text me in the chat box. Exactly. So the shear test is something we should do. The lunotriquetral shear test is something we should importantly do for this case because we have identified the tenderness over the lunotriquetral area. I hope it is very clear. Exactly, the regal test is another name of the test. It's another it's a regal test is also a different lunotriquetral ligament test. So hope you understood. So now we are going to the interventions for risk conditions. Again, it's a big topic, how we are intervening the risk cases. So for me, the major things which I do for in TFCC, ligament instability, all these conditions, is I try to load the area in a progressive manner. And I try to mobilize the structure with the manual therapy. And I sometimes protect the structure with taping. This lunotriquetral injury is something which I used to see very common. So I use specific taping for the protection of that area in the early phase of rehab. And later, once I started loading the joint in different positions, then I try to remove the taping and implement more of focused rehab exercises. And in the acute phase, obviously, to reduce the pain, I do manual therapy as well. So these 3 interventions are something which I focus on performing in the risk cases. But again, that will be different for DRUJ, TFCC. The exercises will be different, and the procedure of doing like a progressive step by step, what to be done first, what to be done next. That will be there in our future workshops. There will be direct workshops we will be conducting. So in that workshops, we will address the interventions of the risk conditions. So these are the major thing, and the major take home message of this webinar is of today is, don't consider or don't pretend that all ulnar-sided wrist pain is TFCC. It can be TFCC or it cannot. Don't go to with a predetermined mind to a patient and do the treatment, because a TFCC rehab and a lunotriquetral rehab or a scapholunate rehab have a very different outcome as well as very different procedure. So each injury, even TFCC, ulnar impaction or lunotriquetral, or whatever the structural injury is there, or even fracture of the hook of the hamate, for each condition, the exercise varies and the dosage of exercise varies. Along with that, the manual therapy techniques also will have different. For example, if you get a patient with a post-fracture condition, post-fracture stiffness, for him, the mobilization technique will be completely, for example, I will be more focusing on the adduction rotation movement. So the mobilization technique will be entirely different for a post-fracture immobilization compared to a ligament instability case. So you should be always thorough with the diagnostic part, and I expect you got some information or got some diagnostic framework how to see a case in your OPD with a ulnar pain case. So that's about today's class, and now it's a time for you to ask me any doubts you have.